Welcome back to the deep dive. Today, we're grabbing the sources used by emergency medical professionals, and we're taking a really close look at medical terminology. It can seem, like this impenetrable wall of Greek and Latin, but our mission today is really to show you that it's actually a highly efficient, systematic code.
Yeah, definitely systematic.
We aren't trying to make you memorize an entire dictionary here. We just want to arm you with the fundamental structure. The idea is once you know the rules of how these words are built, you can decode almost any clinical term pretty quickly.
hmm
It's kind of a shortcut to being well-informed, really.
And that system is absolutely necessary.
Mhm.
Its main job is enabling rapid, precise documentation and communication between professionals. When time is critical, you need that shorthand, that technical accuracy. Speed matters.
But there's a flip side, isn't there?
Oh, absolutely. We have to stress this right away. That precision. It's for colleagues. If you're talking directly to a patient or their family, you absolutely must switch gears. Use simple language. You should never use jargon in a way that obscures the truth or, frankly, intimidates someone who just needs clarity.
Okay, right. So let's unpack this system then. Starting with the literal building blocks. Think of medical terms like, I don't know, complex Lego sets. Almost every single word is built from maybe 4 core parts.
Mhm.
The first one is the word root.
Right, the foundation.
Yeah, the foundation, the stem. It's the essential meaning. And it usually points to a body part or maybe a system like cardio for heart.
Or nephro for kidney. That root gives you the subject.
Okay, the subject. Then you look for the suffix. That comes after the root.
Always after the root, yes. And the suffix is crucial. It usually defines the purpose, like, is this a procedure, a condition, a disease? Think of common ones like anectomy, meaning removal.
Or anxiety. That's inflammation, right?
Exactly, inflammation.
Okay. And before the root, sometimes there's a prefix. Optional, you said. Often optional, yeah. Prefixes generally describe things like location, peri, meaning around.
Or intensity, like tashi, meaning rapid.
Precisely. Location or intensity.
And the fourth piece, the one people forget.
Ah, yes. The combining vowel. Usually it's the letter O. Its role is purely practical. It just joins components together smoothly, makes things easier to pronounce.
So without it, gastroenterology becomes gastroenterology.
Exactly. Hard to say. The vowel is like linguistic lubricant. Makes it flow.
It really is a logical system when you break it down like that, but here's where it gets tricky, right? The high-stakes part.
Definitely.
You have to be absolutely meticulous about spelling, even when words sound almost the same.
This is so critical.
Yeah.
Honestly, a single vowel or consonant change can completely alter the meaning, the diagnosis. Let's take 2 really common suffixes from Greek. Phasia, which means speaking,
Okay, speaking.
versus phagia, meaning eating or swallowing.
Phasia. Very close.
Very close. Now, combine either of those with the prefix dysphys, which
Yeah.
means difficult or painful. So now you have dysphagia, difficulty speaking,
Uh-huh.
and dysphagia, difficulty eating or swallowing.
Wow. They sound almost identical.
They do. But one points to maybe a neurological issue, a speech problem. The other is a critical GI issue. Mixing those up, that could delay the right treatment, potentially life-saving treatment.
That distinction, speaking versus swallowing, that's huge. And the sources had another great example of this sound-alike danger. 2 words pronounced the same,
I know the one you mean.
spelled differently, totally different body parts.
Yep. Ilium, spelled I-L-I-U-M, that's the big pelvic bone.
Right.
And ileum, I-L-E-U-M, the last part of the small intestine.
Imagine just saying ileum pain over the radio without spelling it. Huge potential for confusion.
Exactly. Spelling and context matter immensely. Now let's circle back to prefixes and just how powerful they are. Almost like algebra. Take the word root, nia. That refers to breathing.
Okay, nia, breathing.
Now, just by swapping that optional prefix, you completely change the clinical picture.
So apnea, the A means without, so without breathing.
Correct. Absence of breathing.
And if we hear bradypnea, brady means slow.
Slow breathing. Instantly you know that.
And the opposite, tachypnea, must be rapid breathing.
Rapid breathing. See? It's incredibly efficient shorthand.
That's really clear.
And we see that same power with suffixes. You mentioned arthro, meaning joint.
Yeah.
Combine that with the super common suffix for inflammation, dysidatus, and boom, arthritis.
Inflammation of the joints?
The system really is designed to be decoded on the fly, not just memorized list by list.
Okay, decoding the words is one thing, but now let's shift gears. Applying this precision to location, you can't just say, oh, there's a cut on the arm. You need more, right? These directional and positional terms, they create like a universal map of the body, essential for pinpointing things.
Absolutely essential. because every term gives a precise frame of reference. And crucially, it's consistent no matter how the patient is actually positioned, lying down, sitting up, whatever. The easiest way to learn them is to think in pairs, opposites.
Okay.
So we have anterior, which is the front surface. Some also call it ventral.
Yeah. And interior front, got it.
And its opposite is posterior for the back surface, or dorsal.
Wait, posterior and dorsal. I always seem to mix those two up. Is there like a quick trick?
There was a good one, yeah. A little street smarts tip from the sources. Think of a dolphin or a shark. They have that big fin on their back, right?
A dorsal fin.
Exactly. The dorsal fin. It's always on the animal's back. It's posterior side. That mental link helps lock dorsal to the back surface of the human body, too.
Ah, okay, dorsal fin on the back. That helps. Okay, what's next?
Moving up and down the body, we use superior, meaning closer to the head.
Superior towards the head.
And its opposite, inferior, meaning closer to the feet.
Okay, superior, inferior. Makes sense.
Then we get into terms that can be a little trickier because they're relative, proximal and distal.
Ah, yes. These are just for arms and legs, right? The extremities.
Correct. Only for the extremities.
This is where I always need the clarification. Proximal means closer. Distal means farther away. But closer or farther from what? How do you nail this down under pressure?
Good question. They're always relative to the trunk of the body. Or you can think of it as the point where the limb attaches.
The trunk or point of attachment. Okay.
So let's use the example from our source material. Think about your arm. The shoulder is the attachment point. Your elbow is distal to the shoulder, meaning it's farther away from the trunk than the shoulder is.
Okay, elbow is distal to the shoulder.
The elbow is proximal to the wrist, meaning it's closer to the trunk than the wrist is.
Yeah. Okay, it depends what we're comparing it to relative to the trunk. That makes sense now.
Exactly. Understanding that frame of reference is key.
All right. What about mapping side to side?
For that, we use medial for anything closer to the body's midline, that imaginary line down the center.
Medial, towards the middle.
And lateral for anything farther away from the midline, towards the sides.
So if you report a lateral laceration on the leg, that's way faster and clearer than saying a cut on the outside edge of the leg, isn't it?
Much clearer. Because outside edge could be interpreted differently, but lateral. It immediately tells everyone exactly where to look relative to that central axis. It's unambiguous.
Precision.
Love it.
Achieved. Okay, our final pair for location is superficial.
On or near the skin.
Yep. And deep, meaning farther inside the body, away from the surface.
Got it. Now, there was a really important rule mentioned about right and left.
Oh, yes. Non-negotiable rule here. When you're documenting or communicating, right and left always refer to the patient's right and left sides.
Always the patient's perspective, not your own.
Never your own. Always reference the person you are treating. That avoids potentially catastrophic confusion.
Makes sense. Okay, beyond just location, we also need terms for how the patient is actually positioned, their orientation. We've all heard prone and supine.
Right. Supine is lying face up. Think up towards the sky. Often used for exams.
Supine is face up.
Prone is lying face down. Useful sometimes for accessing the back or maybe certain respiratory situations.
And there was another position mentioned, Fowler.
Yes, the Fowler position. Very common. That's when the patient is sitting upright, or at least partially upright. It's named after Dr. George R. Fowler. And it's used so often because sitting up generally helps patients breathe more easily.
Right, makes sense.
And depending on the angle, we might specify semi-Fowler, which is about a 45-degree angle.
Kind of halfway up.
Yeah. Or high Fowler, which is sitting almost straight up, closer to 90 degrees.
Okay. And then quickly, terms for movement.
Well, also usually in pairs. Flexion is decreasing the angle of a joint, like bending your elbow.
Flexing your bicep.
Exactly. And its opposite is extension, which increases that angle, straightening the joint back out.
Straightening the elbow. Got it.
Similarly, adduction thing adding to the body is motion toward the midline.
Bringing your arm back to your side.
Perfect. While abduction thing being abducted or taken away is motion away from the midline.
Moving your arm out to the side.
Right. So if a doctor orders the arm to be kept abducted, you know it needs to stay away from the patient's body.
Makes sense. And finally, for the abdomen, there's a standard map too, isn't there? The quadrants.
Yep, so 4 abdominal quadrants. We divide the abdomen with imaginary lines, one vertical and one horizontal, intersecting right at the umbilicus, the belly button.
Creating 4 sections.
Right upper quadrant, RUQ, left upper quadrant, LUQ, right lower quadrant, RLQ, and left lower quadrant, LLQ.
So if you report pain in the RLQ, everyone immediately thinks appendix.
Pretty much.
Yeah.
It gives a very specific area for everyone to focus on, standardized and efficient.
Okay. So we've built the words, we've mapped the body. Now here's where it gets maybe even more interesting and maybe whiskier. Let's talk about the shorthand. Abbreviations, symbols. The stuff used to speed up communication and charting, like medical texting almost.
It really is like texting in some ways. Shorthand is vital for speed, no question, but we need to be clear about what kind we're using. There's a difference between, say, a simple abbreviation like PrEP for prepare.
Okay.
Then you have initialisms like EMT. You pronounce each letter, EMT.
Right.
And then acronyms like sample history. You pronounce that as a single word, sample E.
Ah, okay. Initialism versus acronym. Good distinction.
And of course, symbols, like an upward arrow for increased or a downward arrow for decreased, or the standard symbols for male, urine, female.
Let's look at just how much info this shorthand can pack in. The sources gave a great example. Imagine getting a report on a 79-year-old female patient, and her history is just rattled off as AAA, HTN, CHF, AMI, GERD, and type 1 DM.
Whoa. Okay, yeah. That is a ton of critical information condensed right there.
Let's break that down. What does that first bit tell you? AAA, HTN, CHF.
Instantly, that paints a picture of her cardiovascular and vascular health.
Okay.
AAA is an abdominal aortic aneurysm, very serious.
Okay.
HTN is hypertension, or high blood pressure.
Uh-huh.
And CHF is congestive heart failure. So 3 major conditions conveyed in seconds. The speed advantage, especially in an emergency, is undeniable. We probably saved, 20 seconds just saying those 3 things?
20 seconds can be huge. But saving time always comes with risk, doesn't it? How do you stop confusion? What if multiple things have the same initials? Aren't abbreviations just asking for trouble sometimes?
That is the constant tension, the ongoing battle in healthcare communication. And that risk is precisely why major organizations like the Joint Commission or the Institute for Safe Medication Practices, why they publish and constantly update these do not use lists.
Lists of abbreviations known to cause errors.
Exactly. Abbreviations that are easily mistaken for something else, potentially leading to dangerous mistakes. So going back to that patient's history, AMI is acute myocardial infarction, a heart attack. GERD is gastroesophageal reflux disease, and type 1 DM is type 1 diabetes mellitus. Using those abbreviations is only safe if they are absolutely universally understood and accepted where you work and by who you're talking to.
So the takeaway is?
The takeaway has to be this. Conciseness saves time, yes, especially in emergencies. But that conciseness can never come at the expense of clarity. If there's even the slightest chance of misinterpretation, spell it out. Take the extra few seconds. Clarity in documentation and communication, it's fundamentally about patient safety. It can be life-saving.
Absolutely. Which brings us right back around to documentation, doesn't it? Using the correct accepted terminology we talked about, the standardized abbreviations when appropriate, and especially those precise directional terms. Like instead of a lump near the belly button describing a pulsing mass as periumbilical meaning around the umbilicus and superior to the umbilicus meaning above it.
Yeah. Yes. That level of detail.
That doesn't just cut down ambiguity for the next person reading your chart. It also really enhances your own professional standing. It shows competence and care.
Well said.
So what does this all boil down to? We've kind of proven, I think, that medical language isn't just this big, scary hurdle of memorization. It's actually a highly functional code.
Yeah.
If you understand the 4 components, the root, prefix, suffix, and combining vowel, you've got the key to decode almost any clinical term and those directional pairs. They give you that universal map for the human body. You essentially have the keys to the kingdom of clinical communication now.
And our final thought really just echoes what we said at the start. This is fundamentally about safety. Being accurate with medical language, whether you're writing it down in a chart or saying it in a verbal report, it's maybe the highest form of patient advocacy you can practice. Precision protects patients from errors. Simple as that. Speaking of precision, and this is kind of a neat little detail, we learned that making words plural usually just means adding an "es" in English, right? But medical terminology, because it borrows so heavily from Latin and Greek, it has some surprising, kind of tricky rules for plurals.
Oh, yeah.
And this isn't just grammar pedantry, is it? It can actually be a communication hazard.
It absolutely can be, because using the wrong plural form could genuinely confuse someone about the scope of a problem. Are we talking about one diagnosis or several, one finding or multiple? For instance, many singular words that end in "ises." They often change to "is" to become plural. The classic example is diagnosis.
Right, one diagnosis.
Becomes multiple diagnoses, ends in "is."
Okay, diagnosis, diagnoses.
Or think about singular words ending in "isis," like bronchus, one airway tube in the lungs.
Uh-huh.
The plural isn't bronchuses, It changes to eus, so it becomes bronchi.
Bronchus becomes bronchi. Okay,
Mm.
different rule.
Different rule. So here's a little challenge for you listening. Think about how many other common medical or even non-medical words might follow these kinds of hidden, complicated rules. Rules that really could impact clear communication. Maybe look up the proper plural forms for, say, ganglion
Ganglion, okay?
and apex.
Apex, like the top of the lung.
Exactly. See how they change when you talk about more than one? Mastering those little details ensures you're always reporting accurately, whether you're dealing with one issue or you're dealing with several. It all comes back to precision.